Hi, my name is Dr. Charles Moon from Cedars-Sinai Medical Center in Los Angeles. We're putting together a case-based discussion of bone substitutes and other new trauma technologies, mostly bone substitutes, um, for your enjoyment today. This is a recorded session, and with me I have Dr. Geoffrey Marecek, who is one of my partners and is our director of our Limb Salvage Institute. We have Dr. Christopher Max Hoshino, who is from just a little bit south of us at Harbor, UCLA, who's a high volume trauma surgeon there. And then I've joined us all the way from the East Coast, and thank you very much. Got Dr. Christopher Miller, who has joined us from Harvard. He's predominantly a foot and ankle surgeon, but definitely has a lot of experience with post-traumatic and acute trauma of the foot and ankle region as well. So we're going to get started here. And I think it will be Dr. Marecek first. So if we could get your talk going.
All right. Thanks, Chuck. Happy to help when my chief says to jump, we say hi. So just some relevant disclosures to this talk. I am a consultant for a company called Bone Support that makes Cerament, and did some work with Zimmer Biomet on educating regarding their Enforce, which we'll talk about here. All other disclosures are in the program. So we're going to show a couple different cases today, and largely around bone defects in the subchondral region or the periarticular region in order to support our articular reductions. And so as you look at these x-rays, you may think that these cases are fairly similar, fairly different, but my hope is to highlight some of the decision-making about how to choose a bone graft substitute in different cases. So we'll try to understand different options and talk about a bit of a decision-making algorithm. So I think when you start delving into bone substitutes, you very quickly feel a little bit overwhelmed, kind of like this guy. And there's just so much out there that it's really hard to know what you're looking at. And so I think we're all familiar with the use of allograft, and have seen or have used allograft chips, and some of us may have even used structural fibular allograft for periarticular applications to support our reductions. And this is pretty tried and true and works pretty well, but it does take time. It does carry a small, if not minuscule, risk of disease transmission. And it definitely requires some attention to detail. And if you're going to do it right, it takes a little bit of time. And really, since Tony Russell's paper on the use of a calcium phosphate bone graft substitute in tibial plateau fractures came out in 2008, there's been a big boom in this type of thing. Most of the different large trauma companies have their own version of some sort of calcium phosphate putty, and a number of other companies have made either moldable putties or different delivery devices or other calcium sulfate ceramics that are supported by different levels of evidence. And so as you get out there and start to read that, it again becomes a little bit confusing in what to use. So really, in my mind, when I'm making a decision, I try to look at a couple different factors. In the cases that we're going to talk about today, in all of them, we're looking for compressive strength. So we're trying to support an articular reduction. And so it's important that whatever we use has good compressive strength, as opposed to, say, a non-structural metaphyseal defect that is not trauma related, in which case it may not be a concern. But from there, the different things that I want to know is, how big is the defect? Is it small, large, or massive? Do I have direct access to it through a fracture line, or do I only have indirect access to it? And how is the defect contained? Is it well contained with good reductions, or is there a bunch of comminution or bone loss that's going to make it exposed? And that's going to drive decision making. So if we start, we can look at this patient who is a early 60s woman who was walking in Cabo and got hit by a wave. And she sustained this Schatzker 2 tibial plateau fracture, pretty routine fracture, although she does have a pretty severe amount of depression. And here you can see a representative CT scan. And so this case, in my mind, proceeds kind of like any other normal case. We elevate the articular surface, we reduce it and hold it. And at this point, we need to decide how we want to fill that gap. And so in this case, we have a moderately sized defect. This defect is closed. We have really great cortical reads and reduction and no comminution. And again, we're looking for compressive strength. And so in this case, I chose to use a fenestrated screw to deliver a calcium phosphate bone putty. This allows sort of it can be placed through the defect and deliver the calcium phosphate exactly where you want it. I find this to be fairly easy to use and has had good results. We wrote up a case series with Dr. Scalero from UC Irvine earlier this year with our earlier results. But generally, it allows the calcium phosphate to go exactly where you want it, and is one method of putting that into the defect. And so again, for closed defects that are small to large in size, I think this is a useful tool that helps the calcium phosphate get exactly where you want it. And here she is about 5 to 6 months out. You can start to see some resorption on the periphery and a maintenance of reduction. Let's contrast that to this case. This is a 40s gentleman who fell off a roof where he's a maintenance man, and he sustained this pretty severe bicondylar tibial plateau fracture. And he got a caca fix by an outside surgeon, but you can see the bicondylar nature of this plateau and that it's fairly comminuted. Here's a representative CT scan. And so you can see a lot of the comminution and the need to work on it. And so immediately post-operatively, you can see what was done here. But after restoring the medial block and the lateral joint line, again, we need to support our articular reduction. In this case, we only have indirect access to the defect. We can't directly pack things into it, but it's not a closed system. So there's a lot of comminution. There's a lot of small cracks and fracture lines. And one thing about the end force is that it flows extremely well because it goes through this screw. And so it will go wherever you allow it to go. And so in this case, I opted for a more traditional calcium phosphate putty that is injectable, and that can be placed just through a small drill hole and through a cannula into the defect exactly where you want to put it. And once it's kind of in there, it'll generally stay in place and then can go on and support this patient to union, where you can see it's still sticking around exactly where we wanted it to be. Here's a little bit of a different flavor of a case. This again is a young guy who had a huge marble slab fall on him and crush his leg. And you can see that he has a pretty severe lateral condyle fracture of the tibia. And intraoperatively, you can see after reduction that he's left with a pretty massive bone void. And so this case differs a little bit from the previous two because this is, number one, an extremely large defect, and two, we have direct access to it. And so a couple things I do differently when I have direct access. One is that I'm much more likely to use a structural fibular strut or fibular allograft. And though I didn't in this particular case, it makes it fairly easy to wedge it in and gives pretty sound structural support. Second thing is that I generally go for something with that's a little bit easier to handle. So in this case, a moldable putty that can be mixed by hand, can be mixed with antibiotics, and then was packed into the defect. And we closed the cortex around that, and then we're able to apply a plate to neutralize our lag screws and put some unicortical locking screws into this really small peripheral fragment. And then we got him out to union. I need to update that with the year out pictures. They look the same. So lastly, we'll talk about a little bit of a different flavor. This is a 70-something woman who was involved in a car crash. She had a femur fracture on the other side. And you can see this sort of, whether you want to call it a hyperextension variant or a fracture dislocation, but a bicondylar plateau with some anterior crush in addition to varus. And so, and I'm sorry, lost the other things, but this was a highly comminuted fracture with a lot of medial bone loss. And so in addition to being a massive defect, we had direct access here. And so she got two different approaches. First, we used structural fibulas to support the major segments and occupy a large amount of volume. And then anteriorly, she had a lot of bone loss and no way to support that. And so we, again, used a moldable calcium phosphate putty that was able to reconstitute some of that anterior cortex and be placed directly by hand and then provide structural support. And so here on the final post-ops, you can see those fibular struts within the metaphysis going from medial to lateral, as well as one underneath the lateral joint, and then that calcium phosphate putty supporting it. And so here are her x-rays. So in summary, these patients really require, I think, just kind of a thoughtful examination of what you're trying to achieve. Based on what the fracture gives you, you'll be able to decide the optimal tool to use. And while I generally use either a calcium phosphate putty or fibular allograft, there are other options out there that are supported by the literature. And as long as you understand what you're trying to achieve and become a little bit more than a one-trick pony, I think you can have pretty good success in treating these types of injuries. So thanks again, Chuck, for having me, and we'll turn it back to you.
Thank you, Jeff. That was excellent. And again, I think it gives a really good overview of kind of options for tibial plateau fractures in particular, or fractures about the knee, I guess, more particularly. I think is a big important point you bring up about direct access or indirect access and contained versus uncontained defects, because some of this, as you noted, the N-force in particular, if you got an uncontained defect, it's going to go
everywhere.
Yeah.
Yeah, I mean, there are a few ways to mitigate that. I mean, sometimes putting it'll even come out of your K-wire holes. So putting like some bone wax and things, places where you have small cracks, will really help keep it where you want it to go if you choose to use that. It works great. It gets into all the nooks and crannies, but it also gets out of all the nooks and crannies if you let it.
Okay, excellent. And I think one of the things that's sort of underappreciated is the utility of, I think, fibulas and body parts that we don't, I mean, everyone kind of thinks about the fibula in the proximal humerus, but I think there's not a lot of translation of that necessarily. And, it makes a lot of, especially we see a good number of these geriatric and really impacted fractures. And once you dial them out, we end up with these giant holes, and I think it's really very useful there.
Yeah, it's incredibly powerful. I mean, I'm using more fibulas now than ever, and I think that's more related to my move across town, where I'm seeing a lot more bicondylar plateaus, and the people aren't 20 that are having them, or it's not construction accidents, it's struck by autos, etc. But in some ways, also the putty has replaced fibulas a little bit. I mean, there was a time where I was putting fibulas in olecranons and other things for transolecranon fracture dislocations, and the moldable putty has made it much easier to have something that you can similarly manipulate and put into place. But I think for larger defects, there's still no substitute for a nice fibular strut.
Hey, Jeff, Max Oshino. Hey, so a question for you. What if you get a little bit of the calcium phosphate in the joint? Like, not a huge amount. What if you just get a little bit? Do you go chasing after it? Do you think it's a huge problem?
I think it's pretty easy to clear away while it's curing. And so once I inject it, I just tend to really aggressively irrigate the knee and put my sucker in there, and then I haven't had any issues with it. So yeah, I have had a couple like calcaneal fractures where it's escaped a little bit medial and plantar, and later it's given a little bit of a inflammatory response to people. But in general, I haven't had a problem with it getting in the joint.
Yeah, I was going to mention the calcaneal fractures. I've had that happen to me coming out medially. And one person did have a little irritation of the nerve. I had to go back in and take it out afterwards and do a little tarsal tunnel release. So I would definitely look for that now in my Harris heel views.
Yeah.
And Jeff, do you always put a supplement in for every metaphyseal defect? Because sometimes, just to mention, maybe, I mean, the cost of these can cost, you know, your 5 cc's of your calcium phosphate can cost as much as the rest of your construct.
Yeah, I mean, I am putting something in. If I have a metaphyseal defect, I am routinely grafting it if there is articular injury. So, you know, if I have like a plafond rather than a pilon where there's maybe a simple split, but there's a lot of comminution in the metaphysis, I'm not going to graft that. But if I'm supporting an articular reduction, I'm going to use something. I will still use allograft chips occasionally. Chuck and I have a partner who uses them pretty much all the time. But it's just so much easier to use these that that's my preference at this point in time.
I agree. And I think you make the benefit that the patient gets on potentially earlier weight bearing totally, and less subsidence of your joint totally makes sense.
Okay, that was fantastic. And I think Dr. Hoshino, you are next on the agenda. And Max is going to talk about something I think is pretty interesting personally. Take it away if you can.
Yep. I'm trying to start my video, but I think the host has to let me. I'll share my screen. Okay, great. Can you guys see that?
Yes. Yes.
Okay, perfect. All right, so I'm going to talk about some new devices to supplement plating and why to use them and when to use them. So let's get to it. Those are my disclosures, none of which have any impact on this talk. So these are the areas that we're traditionally plating a lot. And we're moving, again, I think in the trauma world towards doing a lot more nailing of these type of injuries. But if we are plating, these are sort of the issues. So you tend to, in the proximal tibia, distal femur, and proximal femur and proximal humerus, you tend to hang your articular work off of a laterally based plate. And so there are some mechanical disadvantages to that. And that's sort of what I'll go through here. So these are just some examples of those mechanical disadvantages. So this varus malunion, non-union of this periprosthetic femur, which required a revision below. This patient, again, varus collapse, hanging the articular block of the proximal tibia off of a laterally based locking plate. And of course, we all know in the proximal humerus, these varus injuries can continue to go into varus, and your locking screws, particularly at the top, as it settles, will have a tendency to cut out far too often. So the current solutions, so the first thing was the blade plate, then followed to the locking plate. And then in some situations, we'll go to dual plating. There's a lot more nail plate combos that are going on. Just periarticular nailing in general has really taken off. And then this talk is about supplementing your plating if you want to do a plate and you don't feel that the other options are possible in the particular case that you're looking at. So again, a couple ways you could potentially supplement. So nitinol cage, fibular struts, and calcium phosphate type cements seen there. But this is sort of how I got interested in it. We'll just do a case-based example, and this is, we've already heard mention from Dr. Moon and Dr. Marecek about a lot of use of fibular allograft struts for strength. And so this is one other way to use them. So 70-year-old male had this plateau here. And I thought because of the tubercle fragment being separate, it was a little bit, would be a little bit of a challenging nail, although it's possible that you could nail. That would be up for debate, as there's not a lot of articular injury there. So patient got placed into sort of a funky external fixator, and had the soft tissue injury there is seen on the medial side of the tibia, and the lateral side pristine. So it'd be a nice place to plate laterally, but there's so much comminution. Again, you worry about that malunion hanging the whole articular block off of your lateral base plate. So again, this is just utilizing a fibular strut through the fracture, making a pathway for it, and then perking a plate. Oh, excuse me. So, there we go. So fibular strut for your medial column support, then perking your laterally based plate, and then getting your tubercle reduced and some screws. And you end up with this triangular kind of construct where you have a laterally based plate, something medial, and then rafting screws to complete the triangle, allowing, hopefully preventing varus collapse. And so that's what it looks like when you're done. So all the work is on the lateral side, and you can avoid that plating of the medial, making an incision to plate the medial side. And here's sort of another example of how I've used fibular struts, just a periprosthetic. You could argue that you could do a nail with this with the better nails now with a cluster of distal screws, and that's an open box knee. But this patient, again, fibular strut, got a nail, slight golf club deformity, but ultimately went on to heal fine there. So this is getting to some newer devices now that I'm using to do very similar things, and I think in a much easier way. The fibula has to be fashioned by you with a saw and fit in, and also it has to go in through the fracture, and it's difficult to insert any other way. You can ream and put the fibula in like you would a nail, but it can be challenging to get it in, and you're making a hole in the bone. So this device is a light cured epoxy in a Dacron balloon that essentially expands to meet the canal and metaphyseal width. And there's a bunch of different sizes of these. And they go in, and it's kind of cool in the operating room because you get a nice light show. Dr. Moon, I know you love that right picture. And you can put these in through some super small incisions, and sort of, so this is a standalone case, just to show how small those incisions can be on the shoulder using this epoxy cured essentially nail that expands within the canal to fix a proximal humerus in a 96-year-old. But onto the cases. So this is kind of trying to think a little bit outside the box to figure out whether or not to fix this bicondylar plateau in a frail, homeless chain smoker who fell 3 weeks ago, but does walk. So here are images. It doesn't seem like too much going on there. And we definitely considered treating her non-operatively, but she couldn't walk, and she really wanted us to let her weight bear so that she could take care of herself when given her difficult social situation. So let's see if this will play here. Yeah, so she had that medial column injury there, and then she had this lateral column injury. So mostly all just depression, and I think we can skip that. So this is what I did all through very percutaneous, maybe 3 or 4 5mm incisions. So first I put a guide wire up to essentially place a strut across that medial column. So that's a guide wire placed right into that posterior medial area, and then a reamer to create a path for the balloon. And this is the balloon that goes in and supports the medial column right into the spot where she had the starting to have that shear injury of the posterior medial column. And then introduced through a separate small incision a fracture balloon, and utilizing a balloon, we're able to reduce her plateau to pretty close to anatomic. And then the key here is to fixate that small depressed fragment with these K-wires, which are you have to sort of place right above the balloon, try not to pop the balloon, and then remove that balloon, and then insert your calcium phosphate cement underneath of it and place it with additional headless compression screws, sort of as rebar. But I think most of the strength here is from the epoxy and from the calcium phosphate cement. And she was able to walk on this with no pain and less chance of having an infection with a small approach that's required for this. Another sort of representative case, 74-year-old female, difficult patient, Jehovah's Witness, BMI 62, had an open distal femur fracture. She was a non-smoker but diabetic. So challenging patient, had this distal femur. And again, you could argue it's possible to nail this. And it was pretty distal, and be interested to see if anybody if the panel would attempt a nail on this. I felt it was fairly distal, did have intra-articular split right where the nail would go in. Really no bone at all. You can see on the 3D recon on the right-hand side, on the lateral, that you can pretty much see through her femur because there's no bone. And I just put that other image in there to show how big her leg is. So she's a very, very large lady. So I put her joint back together, and I put some wires through the notch because her bone was so bad that nothing was holding except for that notch bone. But we was able to get a anatomic reduction of the joint, which was a fairly simple thing. And I put a guide wire up through a very small 5mm incision for the Illuminos device. And then that's the Illuminos device deployed within the epoxy device deployed within the canal, filling it and giving it a lot of extra, well, not bone stock, but a lot of extra strength for placing a percutaneous laterally based plate. And again, I did actually put a screw intentionally through her notch because that was the only place where there was some reasonable bone there for the to hold the articular reduction. And then, so that's how she ended up. The one nice thing is the intramedullary device really holds the reduction during the percutaneous plating almost perfectly. So you don't have to, so you're really just using the percutaneous plating portion as like a sawbones exercise. And that's it. And thank you very much.
This thing really intrigues me. How do you kind of control, I guess, how far the balloon goes? Is it sort of like, because it couldn't quite tell on your things, but as you insert, does the inserter have a set length and that's the length of the balloon, or? So
I think of it as pretty much as putting in a nail, but you can use much smaller instruments because the balloon starts out as, I believe, about 6 or 7 millimeters. So what I use is you can use a guide wire off of a large cannulated screw set and a reamer. So like off of a standard 6.5/7.3 set or off of a large AccuTrack set. You use a guide wire and the drill, the cannulated drill, to make a very small hole somewhere. Then you introduce a fixed length balloon. So there's a number of different sizes of that balloon in length and diameter as to how big it'll get. So then you insert your balloon and you check it. And then what you want to do is you want to fill and then you take a syringe full of liquid epoxy, and you really need to expand that balloon as much as possible. The time when you have a risk of a higher failure risk is if you don't get good expansion of the balloon, because it ends up star shaped if you don't expand it rather than cylindrical. And they found that that's much weaker. So you really do want to try to get as much of the liquid in as possible. Then once and then at that point you have to check it. You have to make sure everything's perfect, because once it hardens, it's in there forever, pretty much. So then once you're happy that it's perfect, then you put in your light source, and for a set amount of time, it's anywhere from about, probably depending on the monomer, maybe 10 to 15 minutes, 8 to 15 minutes, something like that, while it hardens. And then they have a specialized cutter to cut it. If you need a shorter balloon, there is a technique. to make the balloon shorter, and you should ask the rep on how to do that. That's the basic technique. After it's hard, you can drill through it with pretty much anything. It's like an infinite hole intramedullary nail.
So when you're putting it in, there'll be potentially some balloon and epoxy. It's like sticking out, but you can just cut it off.
Yeah, so you have to. Well, I don't know if it's really in the technique guide, but if you need to shorten it, then you use a device to essentially occlude the portion of the balloon that you want to the amount that you want to shorten, so it doesn't expand when you put in the liquid.
Okay.
So you can kind of customize it shorter. You can't customize it longer. You'll know there's a radiographic marker for the full length of the balloon, so you know when it's fully inserted if you have like the optimal length, and then you can and then the cutter is fairly easy at the end. It just cuts flush with that marker. So I guess my point is the only difficulty is shortening it. But it's possible. You can do it.
Intriguing. I'm fascinated, and those cases are the kind of things we do see a lot of, and that distal femur, I probably would have done a nail plate combo, but this idea of using the Illuminos, making that basic same biomechanical construct, but a lot easier mousetrap, I guess is the way to put it, right?
Definitely. And I mean, my whole thing, and I know you treat a lot of geriatric fractures as well. The whole thing is getting these folks weight bearing, and not just letting them weight bear, but actually having them weight bear because they're not hurting. And I feel that this this definitely has potential for allowing that. And I know all the stuff we're doing of trying to use more nails, nail plate combos, dual plating is all trying to get these folks to weight bear. And I found these people can weight bear. Of course, the downside, like anything in medicine, there's a downside. The downside would be, I would imagine this would be fairly challenging to get out. And I haven't had to take one out yet.
Yeah, that's the one thing that I'm a little bit concerned about, is if something happens and you need to take it out, it looks like more than a little challenge to get it out.
Yeah. I did have one in a very challenging patient for a periprosthetic tibia break. But when I revised the plating on that patient, it was still good to have it, because even though it was broken at the fracture and I had to rely on my plates for stability at the fracture, it still gave me excellent purchase with my screws within those segments. And the patient did fine.
Okay, cool. Well, that is fascinating. I think we'll now move on to Dr. Christopher Miller, joining us from Harvard, and going to show us some cages.
Well, thanks for having me. And this was fun to put together, and they're interesting cases to work on here. So I was asked to talk about 3D printing and some limb salvage applications. So I assume you guys can see this.
Yep.
So these are my disclosures. I do consult for arthritis, mostly on the minimally invasive applications, but no conflicts with regards to this presentation. So I just want to start off briefly. What is 3D printing? I think it's getting out there, and a lot of people have a much better sense than they did even 5 years ago about what this means. But it has a lot of different names, and people will talk about stereolithography or rapid prototyping, but by far the most common is the 3D printing concept. And it's a general concept of additive manufacturing, but you're able to create really complex objects that you couldn't do with traditional manufacturing techniques, such as casting or molding. So trying to create this object on the bottom right would be very challenging unless you're able to print it layer by layer. And there are a lot of different techniques for doing this, and I'm just going to show the one that's used most commonly with orthopedic applications, which is this powder binding. And the powder could be, metal, and then they can heat it and sort of laser sinter it, or it could be other types of powders that they could glue together, but you lay down sequential layers, and then you have something that binds it together, and then you create this object as you're printing it, and it's moving down through the sequential layers here until you get something in this bed, and you can take it out, and now you have this object, which would otherwise be very challenging to make. Sorry. So we want to do something that's going to help our patients, and so we need to think about doing this for metal replacements for bone defects or bones or what have you. And we're going to use the same techniques, but of course we're going to be doing it based off of CT scans. So the first step in all of this, and I'm going to showcase it in a second, but the first step is you have to get high quality CT scans. And then what the companies will do is highlight the bones that you're interested in. You can see this in the purple here. This is in a system called Materialize. And then it creates a 3D model in the computer. And so this was a study that I was working on as a resident, looking at coalitions in the hindfoot. But just so you can see kind of what this looks like in the computer, very high resolution of the bones, which then gets converted in the system and then sent to the 3D printer. So press that. And so this is what the final processing looked like for this particular case. And then you end up with the final print. And so this was a study we were doing with sort of biomodels, and this was a silicon powder that got sort of glued together. So what we're doing in clinical practice, I was trying to create metal implants. And so along those lines, I want to share two cases. The first, and this was my first case of using this, was a 20-year-old woman, restrained passenger versus car, NBC, and she had a Talar body extrusion. And you can see on the x-ray there, there's a small wafer of the head that's left. But unfortunately, the Talar body itself was not recovered. And so she was left here. She was treated elsewhere, placed into an X-fix and antibiotic cement spacer, and cleaned out. And then she had seen several other surgeons who had offered her either some sort of bulk allograft fusion, so with a femoral head, perhaps with either TTC or pan-Talar fusion. Somebody recommended a primary amputation for this. But she was a young girl. She works as a security guard, and she was looking for other solutions. And so she came and we talked about what other options she might have after being in the excerpts for 2 months. So I started off with just a standard sort of infection workup. We looked, the skin was well healed, no erythema, no significant swelling. I aspirated her several times. We gave her a pin holiday. I actually aspirated her again at that surgery to take the X-fix off. And then we obtained bilateral CT scans. And so this is what it looks like. So we send it off to a company. They parse both of the CT scans. And here's a little video showing, this is actually my first time using a Zoom conference. But here you have the engineer showing me what this implant will look like. And so in this case, the gray that you see is her injured side, and then the green is a mirror image of her uninjured talus. So they parse that, and then they just take a mirror image of it. And they're showing me slightly different sizes. They'll give you, a true size and a, 0.95% size, so that you can try and get it in if it's a little bit tighter. And they go through it. So you're working with the company, you're working with the engineers to try and describe what it is that you're looking for here. And in this case, we were trying to do a total talus replacement. And so they're going to take this image file and then they're going to print it out into a metal format for me. So this is what it looks like. It's like a liquid metal, like the Terminator 1000 from the movie. But they send multiple different sizes here, and then they also send trials. So on the left, you can see the trials that you can correspond to the same sizes here, and then you can as you're doing the surgery, you can see here we came directly anterior. We found the cement you can see on the left there, and what was left of her talar head was almost just the subchondral bone, and it just came out. It was almost mush at that point, but fortunately was not infected. And you can see we're trialing it with the first trial. You can see it fits in nicely. And then this is the final implant you can see inside and fits nicely. And it's really just a spacer. So we know that the talus doesn't have any muscle attachments. It obviously has some ligamentous attachments, but in her case, she had this cement spacer in there so long that she'd almost scarred around it. And so all of her ligaments were sort of bypassing any talar attachments anyways. And it was remarkably stable once that was in there. This is what the trials look like, and they usually put a little bit of radiodense powder in there as well so that you can see the outlines better. And then it's really kind of a feel and an X-ray evaluation and looking at it clinically to see is it the right size, does it fit comfortably before picking the final option. And this is what she looked like about 2 years later. And she had been able to walk on it. She did get a little stiff. I had to lengthen her Achilles tendon late, but she was able to return to work as her security guard. She's able to walk. She can't run more than a block or so, but she can get around reasonably well. And she has some light soreness at the end of the day and is left with about 30 degrees of ankle motion. Just briefly, I think the 3D printed talus is one of the most common ones that's being done right now in the foot and ankle world, most commonly for AVN, which we see a lot of in the trauma world after talus fractures and fracture dislocations. And a lot of this is coming out of Duke right now. So Dr. Parekh and Dr. Sam Adams are really at the forefront of this and publishing a fair amount on it. But some of the outcomes with 27 patients and having a significant decrease in VAS, although still relatively high in this study, but they're able to maintain their ankle range of motion. And in this case, one person did go on to amputation because of infection. Sort of midterm outcomes, and some of this is coming out of Japan. And so sort of 3 to 8 year outcomes with ceramic talus is showing improvements in function, and in this one case, no revisions or amputations. And then there are some even further out, 10 to 36 years from Thailand. These are a little bit different because it's just the talar body, which I think is not necessarily what's happening as much anymore, because some other studies have shown that maybe the interface between the bone and the implant here was not as good as this particular study was showing. But at long-term follow-up, 28 of 33 were still in place. So my second case is a case of distal tibial non-union. And so this was a nurse in my system, 58. She had well-controlled diabetes, a little bit of neuropathy, and then she had a pilon fracture, which was treated locally and initially X-fixed and staged ORIF as pretty standard, but obviously went on to hardware breakage non-union and then other surgeries to remove this hardware. But at about 1.5 years following her injury, she came to see me with this deformity here. And so again, we started with the basic workup and we made sure that she didn't have an infection. She had an open biopsy. And the path came back saying, it looked like dead bone, but all the cultures were negative. Again, had been offered amputation previously. They had talked to her about bone transport. And I talked to her about that too. I'm not really a frame guy, but I think that's on the table for these types of critical bone defects as well. And she really tolerated the frame poorly at the initial injury. And I think she even had some pin site infection. So she was not particularly interested in that. And so we talked to her about possibly performing a single stage TTC fusion with this distal tibial cage replacement as well. And so again, you can see the pre-op plan here. The gray is the damaged bone, and then the white is sort of the overlay of the of the intact tibia. And then they can model it out for you. So here we're creating a sort of cage that you can customize. Again, we're working with the company engineers doing Zoom calls, and they can template around whatever type of nail that you want, because they have the image files for all of the common hardware that we're going to use as well. So this was her at the beginning of the case. You can see the recurvatum deformity. We decided to come medially to try and preserve the fibula for some stability. And we resected the entirety of that distal non-united avascular portion of the tibia. And then this is the spacer that I showed you earlier. We place that right in, and we do the reaming and pinning for the TTC directly through that spacer. Obviously, we've already prepped the subtalar joint as well here. And then here are our implants. You can see the spacers, and then I take a combination of DBM and allograft bone, autograft bone, and really just kind of try and throw the kitchen sink into this to try and get some bony ingrowth to this. And then here it is packed with bone. And then here we're lining it up for the nail. And then this is at the end where we're coming in, and you can see it's much straighter here. Being critical, I probably left her about, a couple degrees in Aquinas, but she's doing well with the rocker bottom. And here's her post-op. She's just about a year out now. So she's CT here. And I think you can see some bones are coming down and infiltrating into this implant here from both sides, coming up from the talus as well. And I do like to get a CT scan on these before I let people start weight bearing. It just makes me feel better. It makes them feel better knowing that we're getting some bony ingrowth. This is a nitinol nail, so there's an elastic nitinol core to this to help continue some compression even after we're done, to keep the bone from resorbing at the edges. So, when our first talk was mentioning cost, this is going to blow the cost out of the water for any of your cases. But post-op, she's returned to work. She's working as an RN. She's walking. She does have rocker bottom shoes, but she's really pain-free for the first time. So for me, this was a big win, and she's been quite happy with it. Now, disclosure, I'm not a frame guy. This is a frame from one of my friends, and I showed him this case, and he said that he would do this, which is a cable transport diffusion. Certainly, I think if you have the techniques and the skill set, this would be another reasonable option. For me, I prefer the more acute corrections in a single stage procedure if possible. But a lot of ways to skin a cat. And so from the benefits, we do know, especially in diabetics, that bulk allograft TTCs rarely, if ever, fuse. And so 2 studies in the 2013-14 showed really 100% of them had non-unions around bulk allograft if there was a diabetic. And with the fusion rates around titanium printed cages, we're getting 85+%. And so 2 studies here with 15 patients, 13 of them went on to have a good outcome, pain-free walking and fusion, and the other 2 ended up, unfortunately, with amputations. But certainly if we're thinking about doing any of these, we're in the limb salvage world for sure. And this was another study from the same group looking at fusions with allograft versus the metal cages, showing 92 versus 62% overall fusion rates. So who is a candidate? And a lot of people are not. So if you have an infection, if you have poor tissue quality, you're not going to want to be putting a lot of hardware in here. But in my world, we're doing this for failed total ankle arthroplasties, in particular, talar AVN, as I showed, and then segmental bone loss. So I think it's a really interesting and exciting field within orthopedics. It's not just foot and ankle. The tumor surgeons are really having a heyday with this as well. But it's exciting because it's really only limited by your imagination and what you can think of and how you might want to improve people and get fixation into these complex situations. There are multiple companies that you can use that do really good work, and I've listed some of them here. And certainly these are salvage procedures, and I often think of them as maybe the best option out of a lot of bad options for patients. I never want to do this. It's intellectually interesting and they're exciting cases to do. But if I have another option, I definitely try to do it for them as opposed to a 3D printed bone or replacement. But I encourage you to look into it and see if there's options for your patients as well. Thank you.
That is some pretty cool stuff. What's the turnaround for that talus?
So it depends on the company that you're working with. So the Restored 3D is the one I use. They have a turnaround of 3 to 4 weeks from when you send them the image files.
It's just a standard CT, or is anything special about it?
I mean, fine cuts, so just the highest cut, thinnest cut that you can get for that. And obviously it needs to look the entire area that you're evaluating, but oftentimes I'll send them bilateral CT so that we can compare, especially if there's been shortening or collapse of the talus on one side, then you'll need to model it off the other side.
Yeah, it's sort of interesting that, as noted, replacing artificial talus, so to speak, isn't a new idea. I mean, there's 36-year follow-up. So, and I remember being a resident and reading an article about this and going, "This is craziness." But it's an interesting concept, and it's interesting to see how well does the articular surfaces of the ankle and the subtalar joint hold up to something that's obviously much harder and different than what's supposed to be.
And that, I think that's the question everybody has, and there are certainly surgeons who are very critical of this type of procedure out there, because I mean, after you do a total talus replacement, what's your fallback, right? You're talking about doing a pan-talar fusion, which arguably has worse functional outcomes than a below-knee amputation. So it's, and that's where I talk to people about this being an option that has, if it goes poorly, can have serious ramifications. And so I think it's not something you do casually for patients. Now we have people with 30-year follow-up with some of these ceramic talus. And, I think with some of the 3D printed technology, we can get much more exact replication of the patient's anatomy, which I think can only be a good thing.
Well, I think this was a really cool. You're talking about cost, but the cost of that fusion construct is really driven by the Dyna-nail. I mean, that's expensive, but a run-of-the-mill hindfoot nail and that fusion construct is considerably less than that cable transport construct you were just showing.
Right.
I mean, that ain't cheap either.
No. Well, and once you're getting to that point, I mean, there's probably no cheap options. But the foot and ankle surgeons are sometimes a little inelastic to cost concerns, and the trauma guys are often hounding on us for that. But then they're putting on complex frames and doing cable transport for similar conditions, and so if you're comparing it to that, it's probably cheaper.
Certainly, it's simpler for the patient. They don't have to monitor.
I think so.
It's simpler for the surgeon too, because I mean, you got to monitor that cable transport like a hawk. So, Max, Jeff, any comments or any questions?
No questions. It's always mind-boggling to see these types of cases. I'm been very hesitant to jump on it, just because for the same reason that I don't do hip and knee replacements, which is that once you start putting metal in, I feel like you just have to chase metal with metal. But at some point there may be a need to do it. So I'm curious to see, Chris, what you and other people. There's a lot of promise, and certainly that's where we're going. I just haven't been comfortable enough yet. So thanks.
Yeah, Chuck, Dr. Moon, I've done a few cages, 3D printed cages for bone defects and stuff. Have you done some?
One, literally.
Yeah. The problem is I can never tell, and Chris, you kind of went into this, but it's hard to tell when it's healed. And I've seen some hypertrophy on the, because usually metaphyseal defect and distal tibia or distal femur, and I've seen that hypertrophy of the cortical bone on the more proximal junction, but I never know what's going on in the metaphyseal junction. I haven't seen much happening there. So I just let them weight bear when they can, but I haven't gotten CTs before weight bearing, but that's a good idea. But that's always been tough for me to be like, is it really healed or not healed?
Sometimes it's a leap of faith, because I think even in that one I showed you, it's hard to tell how much the talus may be binding to it. But I just try to pack as much bone as I can in there. And, in that case, I really left as much, I came down to periosteum and kind of shelled the bone out to try and leave as much of that to, hopefully bind to the sides as well.
Well, okay, that was a great session. Very much appreciate your time, gentlemen. And I hope the COA members enjoy this. And I think that we're finished.